We are going live in 3, 2, 1. You may start, sir.
Yeah, good evening, ladies and gentlemen. Welcome to another enriching episode of Blood, the Life Savior. And congratulations to this wonderful team for a continuous web series month on month. Today is episode 13th. And to do the honors, we have the faculties from prestigious Dinanath Mangeshkar Hospital, Pune, a rich work in the field of hematology. And today's topic is a storm that would not settle. And we have another case study on elderly male with massive hemorrhage. We assure you that it's going to be exciting. And all this has been possible because of untiring networking, coordination, guidance by our course director, Professor Dr. Biju George and Professor Dr. Joseph Johnson. Normally, we start on time and we finish on time, and both our course directors are very particular. 1 hour, 30 minutes for each case studies. And it's my honor and privilege to briefly introduce somebody who doesn't need an introduction to the field of hematology, somebody who built an institution such as CMC Bilor, Professor Dr. B.G. George, Professor at Department of Clinical Hematology, CMC Hospital, Bilor, somebody who started there as a student and has reached the pinnacle of that particular department, a clinical scientist with 17 years plus experience in managing hematological disorder, Vice Chair Asia, Africa, Australia Advisory Committee for CIBMTR. Many publications, more than 300 plus publications in prestigious national, international publications, contributions to 6 book chapters. We all are aware about his great regimen proposed fludarabine and cyclophosphamide. Initiated more than 200 plus haploidentical transplant, developed specialized transplant protocols for Fanconi anemia and other cognitive disorder. Areas of interest we know whenever we speak to about Professor Dr. B.G. George, stem cell transplantation, infection management, bone marrow transplant, failure comes to our mind, and what an expert he is. The second gentleman, Professor Dr. M. Joseph John, thank you again, sir, for being a wonderful supporter, mentor, guide for this wonderful program, which has pulled more than a year. Professor Dr. Joseph John is Professor and Head Department of Clinical Hematology at another prestigious CMC Hospital, Ludhiana. Associate Director at that particular institute, more than 30 international and more than 38 national publications, part of 7 book in prestigious national and international publications, and principal investigator in more than 20 clinical trials. A great clinician and great researcher. Many awards and accolades to his credit, and he also went on to establish another institute way back in northern part of India, Clinical Hematology Department and Stem Cell Transplant Services at CMC Department, founded Comprehensive Hemophilia Care Center and later a Center of Excellence as early as 2010. Both our course directors, thank you for your mentorship, guidance, and bringing 13th episode here. May I request you to take it forward from here?
Thank you so much, and welcome everybody to this first episode that we are having in 2026. We'll follow the same pattern that we did for the last 12 episodes. That is, we'll have a presentation, 1 or 2, and today there are 2 presentations, discussion, and in the end, we will take questions from the audience. So please put in your questions into the chat box or Q&A, and we will definitely take it up at the end. I'm happy to introduce Dr. Samir Melinkari. He's a consultant in Dinanath Mangeshkar Hospital, Pune, a close friend of mine. And he's been my student, but now he's a leading authority in hematology in India. Welcome, Samir, to this program, and I request you to take over and please go ahead with the presentation.
I would like to
Thank
add
you,
on
John.
to say that Samir is my batchmate, and we have shared the room multiple occasions for various meetings when we went. Over to Samir. Nice having you here.
Thank you. Um, We are going to have two cases today. The first case is a slightly bigger case, and the second one is a small case. But it's not difficult to diagnose, but it's very rare. I mean, that this is the first case in my life that I have seen, the second one. So it's an interesting one. That's why I thought we should bring that up also. The first case will be presented by Dr. Siddharth Damle, who is our first year resident doctor in DNB. And the second will be presented by Dr. Rameshwar Tiwari, who's just entered his third year of training now. So what we'll do is with your permission, we'll do the first case and do the discussion of that. Otherwise, it will be difficult in the later on. And then the second case and a little bit of discussion, and the questions we can take jointly for both the cases.
That is fine, Samir. Please go ahead.
Yeah. Okay. So Siddharth, please go ahead.
Thank you, sir. So I'll be starting my presentation. Yeah, so is it visible, the presentation?
Yes, it is.
Sir. Go ahead.
Okay, so I'd like to start with the first case, which is a storm that wouldn't settle. So we had a 23-year-old female, primi gravida, who underwent LSCS on the 12th of September for preterm premature rupture of membranes outside. Later developed new onset fever, chills, and foul smelling vaginal discharge since the last 2 to 3 days. She came to Deenanath Mangeshkar at around 20th September. It was sudden onset and progressive. No history of vaginal bleeding, neurodeficits, cough, dyspnea, hematuria, or oliguria. And she was brought to DMH for further management. On examination, she had almost normal vitals, blood cultures, and a vaginal swab were sent, and the patient was started on meropenem and teicoplanin as a broad spectrum. CBC initially showed a hemoglobin of 10.2, mild leukocytosis, and a platelet count of 18,000. There was mild transaminitis and an INR of 1.51. Procal and blood cultures were negative. On the second day, however, she had worsening thrombocytopenia with increasing creatinine. The platelets were 12,000. BP was 150 by 90. PT and APTT had normalized. LDH had gone to 1,300 with increasing indirect bilirubin. And haptoglobulin was undetectable. Creatinine was 1.5. And there were about 2% schistiocytes present in the peripheral smear. So with the ANA blot negative and a plasmic score of about 7 points, it was clear that most likely this was TTP. So ADAM-TS13 levels with inhibitor of ADAM-TS13 levels was sent. The hemoglobin had started to fall to 8 gram per deciliter. Hence, we immediately started the patient on Plex with concurrent IV dexamethasone 8 mg TDS followed by a prednisolone of 60 milligram OD from the second day. The ADAM-TS13 activity came out to be 1.3%, which is very severely low. ADAM-TS13 inhibitor was 1.6 Bethesda titers with an 84% inhibitory activity. Hence, Plex was continued for the same duration. On day 4 of admission and Plex number 4, the platelets count was still 29,000 with persistent schistocytes of up to 3.5%. Hence, this is a slightly resistant disease. Hence, we decided to start IV rituximab directly on the 27th, given weekly for 4 doses throughout the course of the first admission, along with steroids and Plex daily. Due to the resistant nature of the disease, we've considered the other differential diagnosis, and hence bone marrow studies and PET-CT was done on the 6th of October, both of which were normal. Since the steroids were been there for a long period of time, the steroids were tapered and mycophenolate mofetil 1 gram BD was added from the 9th of October. So this is a rough table of how the admission proceeded. With increasing amount, you can see as the each day as the Plex number increased, the platelet count fluctuated a bit and then eventually settled at 49,000 on the 17th of October. The schistocytes kept on decreasing over time. LDH in between was 670, which was decreasing. Since the trend of the platelets were on the upward and post 4 doses of rituximab and clinically stable parameters, the patient was discharged on tapering steroids and mycophenolate mofetil. Decision was taken to continue Plex on OPD basis. So from 18th of October to 23rd of October, the patient underwent plex sessions daily on an OPD basis. The plex platelet remained stable at 49,000 on the 23rd. So a plex-free interval of 3 days was given from the 23rd. However, patient came back with a platelet count of 13,000 with a hemoglobin of 6.8 on the 26th. So the decision was taken to add on bortezomib because still after giving a plex-free interval, the patient had worsening of platelet count and hemoglobin. So bortezomib 2 mg subcutaneously was added weekly. Due to cost constraints and the patient refusal for plex, a decision was taken to transfuse 5 FFP per day for the same without the plex in an order to supplement ADAMTS13 levels without actually removing the inhibitor. Same was continued from 28th of October to the 1st of November. The platelet counts rose from 13K to 37K during the same time. However, patient developed new onset dyspnea of an exertion with increased BP. The patient was admitted and investigation found to have pulmonary edema with an NT-proBNP of 9,000, queried TACO creatinine of 1.6. Patient was managed with NIV and diuretics. Platelets dropped to 27,000 with schistocytes of 2% on the peripheral blood sphere. And the patient also developed blurring of vision, was investigated and found to have serous retinal detachment and choroidopathy on fundoscopy. Most likely it was a worsening of the TMA. Hence, the patient was convinced and daily plex was restarted in her. So this went on for the next 1.5 months. Intermittent plex-free intervals were given, found to have a drop in platelets intermittently whenever the plex was stopped, hence it was continued. We eventually added on bortezomib and cyclophosphamide and dexamethasone every weekly. This continued for 2 months. Patient was also offered the choice of daratumumab but was not opted due to financial reasons. So this is the rough proceedings. So plex number 30, 31, 32 went on these dates. The platelets again were on the higher side but fluctuated. Eventually, by the 29th, the platelets were about 77,000. The schistocytes decreased to 0.4. And in the next subsequent the platelets rose to, went down to 94,000 on the 13th of December. And on the 17th of December, the platelets crossed 150,000 for the first time and were 193,000. And and we continued monitoring her. On the 24th of December, the platelets were 251,000. The schistocytes were nil. So, as of date, most recent follow-up was on the 14th of January. Patient has no symptoms. The platelets are 1.93 lakhs and no schistocytes are present. So this is a case of refractory thrombotic thrombocytopenic purpura. The international working group defines it as a persistent thrombocytopenia after more than 5 plex cycles with steroids. There was a lack of sustained platelet count elevation of more than 50,000, persistently elevated LDH more than 1.5 times normal, failure of clinical improvement or worsening of organ failure. And if the platelet counts are less than 30K post 5 cycles of plex, which was in this case, it is known as severe refractory TTP. So these are the methods or therapeutic agents by which we can use to counter the severe nature of this. Other differential diagnosis must be considered during if the patient has refractory TTP. Hematological cancers like lymphomas or plasmacyte, multiple myelomas can be ruled out by doing marrow and flow cytometry. Solid organ mets, PET CT and appropriate biopsy must be taken. If it is Evans syndrome, positive direct antigen and direct Coombs test can be done. And HLH, we can do HLH markers with marrow studies. Adding rituximab as early as possible along with steroids changes the disease course. Case control studies are present where the time to remission was less and there is a decreased risk of relapse. The dose is about 375 milligram per meter square per week for 4 doses. Anti-von Willebrand factor antibody caplacizumab is a anti-von Willebrand factor domain A1 antibody which impairs the addition of GP1B952 von Willebrand factor. 10 mg IV prior to plex followed by 10 mg subq after each plex cycle is given. Up to 30 days after the end of the last plex, we can give this antibody. It has no effect on autoantibodies. So if it is an immune TTP, it has no disease changing this thing. It is a time saving therapy. It is expensive and it is not available in India as of now. Other therapeutic modalities which have been tried as case control studies are also mycophenolate mofetil, azathioprine, cyclosporin, obinutuzumab, which is anti-CD20 antibody, vincristine, and splenectomy. Later on, plasma cell depletion came out as an important therapeutic modality in refractory TTP. Here, the rationale is depletion of ADAMTS13 inhibitor producing clone of plasma cells post CD20 depletion via rituximab. So once the CD20 cells are depleted, a small proportion of plasma cells continue producing the ADAMTS13 inhibitor. Hence, depletion of these is important to bring the disease under control. Here we can use bortezomib, cyclophosphamide, and daratumumab, which is an anti-CD38 antibody. In this patient, we used bortezomib and cyclophosphamide. Thank you.
Okay, I'll give my comments and then maybe Anushri and Abhijit can just discuss. So this patient, as Siddharth mentioned, sometimes in not just TTP but even ITP and other autoimmune disorders, the B lymphocytes, if you've depleted them adequately, sometimes the plasma cells just take over the job and they start producing antibodies. And as you know, plasma cells have 1,000-fold better capacity to produce antibodies as compared to B lymphocytes. So plasma cells decide to take over, then all your regular treatments with which you're trying to suppress T and B lymphocytes don't work all that well, including rituximab. And therefore, now daratumumab is one of the most upcoming drugs in this field, to tackle these resistant, even in chronic ITP, resistant ITP, dara has been tried with good success now. And in TTP also, there is, of course, anecdotal case studies because we don't need to use it the situation doesn't arise too often. So we wanted to use dara for her, but because of financial constraints, you couldn't do it. Now, so then we decided to use a myeloma-like regimen, which was Cybor-D. Okay, now why we didn't use VRD, why we didn't use lenalidomide? Because you don't use IMIDs in an autoimmune disease because they can worsen the autoimmunity. Okay, so you don't use len, and that is why we use Cybor-D. And we know that in myeloma, how long would it take to eradicate the myeloma clone or deplete of the plasma cells with Cybor-D? It would take somewhere around 2-3 months, right? So you have to be patient. So I had to tell the patient that you got to be very patient. This regimen is not going to act fast. It's going to take about 2-3 months. So until that time, we've got to be persistent. We'll do intermittent, plex or plasma exchange, whatever. So it took almost more than 2 months with Cybor-D itself to get her under good remission, but that persistence helped, and ultimately she is off everything now. She's doing well. So how long to continue this treatment is a little skeptical. You got to probably decide based on how the course was. I think I would give this treatment for something like 6 months and then probably abort it. But I would invite comments from others as well. So maybe Anushri, you can comment.
Good evening, all of you. Just to summarize and give an introduction to the immune TTP, it is a rare condition because of the presence of antibody against ADAMTS13. There is presence of large 1 Willebrand factor multimers, which interacts with platelets and cause microthrombi in the vasculature, which results in microangiopathic hemolytic anemia, thrombocytopenia, tissue ischemia resulting in renal failure, and neurological symptoms and fever. This is the typical presentation of these patients. It is treatment wise, we need 3 approach for these individuals. One is removal of the antibody and the large 1 Willebrand factor multimers by doing a plasma exchange, and meanwhile supplementing the deficient ADAMTS13 levels by replacing plasma as the replenishing fluid while doing plasma exchange. And third is the production of suppression of the antibodies which are being continuously produced, initially targeting the B cell population, and if it is failing, using anti-plasma cell directed approach. 30% of the patients can be refractory to, can have a relapse of the disease, and to prevent that, early administration of rituximab is recommended for all immune-mediated TTPs. And the plasma cell directed approach has already been mentioned. What I would like to add is that how to monitor these patients. Ideally, they should have monthly monitoring of ADAMTS13 activity, and if possible, inhibitor titers, and then we can have a preemptive approach towards maintenance or a fixed interval maintenance. typically the maintenance protocol has been there for rituximab, either 3 monthly rituximab or a preemptive approach when the ADAMTS 13, when the activity drops below 10 to 20%, one can introduce rituximab. DARA also can be used as a maintenance therapy. Initial dose is given as 16 mg per kg weekly, like myeloma regimen, and thereafter one can, once the patient settles down well, one can give us a 3 monthly regimen. In BORT, when I searched the literature, I couldn't find a typical maintenance regimen, but maybe we can, as Dr. Samir was mentioning, maybe we can have a myeloma kind of approach along with the monitoring of ADAMTS 13 activity and monitoring of inhibitor titer levels. That is from my side.
Samir and team, so one of the questions I would sort of look at is there any data or in literature on trying to identify who are the people who are likely to be refractory? Then is there an option of saying, let us combine rituximab with the plasma exchange upfront, or something like that? So is there any data and literature to say that this clinical scenario of patients are more likely to have refractory TTP?
From whatever I've read so far, I haven't come across this concept of, whether you can identify the patients who are worse. I haven't seen any data on that. And sometimes they, as you go along, sometimes initially they start to respond, and all of a sudden then they start to become refractory. Probably that's the time when when you've depleted plasma cells, and then suddenly the B lymphocyte, suddenly the plasma cells probably take over, and then they suddenly start becoming refractory. So I think it's very difficult to predict.
So can I
Yeah,
so
Jyoti.
Samir, this is a very interesting case where, as Anu mentioned, there's a threefold approach: depleting the antibodies, then targeting the CD20, and targeting the plasma cells. Now, is there any study to use upfront bortezomib along with the Ritux? It's almost like a BDR regimen here. No?
Yeah. No, the standard approach has everywhere, from whatever I've read so far, has been, steroids, Plex as the primary backbone, because most patients do respond to this. There's only an occasional
Okay.
patient who doesn't. And rituximab now is upcoming. We use it for all patients. That's the recommendation, because rituximab may shorten the time to remission, but more than that, the main role is to prevent relapses. Distinctly, use of rituximab has prevented relapses. And there have been occasional patients who relapsed TTP, where I'm using rituximab maintenance for, 2 to 3 years. Again, empirical, but that also has helped a couple of my patients.
So, in other words, Ritux is here to prevent long-term,
Yes, to
give you
prevent
long-term
relapses
control, whereas the acute control is Plex and Bot, essentially, right?
and steroids. Not bot.
Correct.
Bot is for those. Bot is for
No,
the
no,
resistant
it
ones.
is it is only logical conclusion that we should. Probably it will come early because it is easy
Yeah,
to give. Maybe it is a good option, but right now
yeah, yeah.
before the bot came, Ritux came, so that may be the reason.
Maybe.
Regarding how to predict somebody who may be refractory, I don't have literature backup, but I was thinking that maybe some indication can be from the inhibitor titer levels, and
Yes.
some patients we find that as soon as we start the plasma exchange, patient starts responding very quickly. So if somebody is not responding in 3 to 4 sessions of plasma exchange, I think we should have a red flag that we need to be a little
Yeah,
cautious with.
that's a good thought. What about the
Yeah.
ANA in this patient? Was there ANA done or
Negative.
ANA was negative? Wow. Okay.
There's in the initial diagnostic workup of a TTP, it is not required to do a PET scan and bone marrow. But I remember distinctly a case of such a refractory TTP who then went away from me to a different place because it wasn't working after some 20 cycles. And then the other person, where the patient went to, he did a bone marrow biopsy, and he found mets in that. It was flooded
Mets.
with solid organ mets. Yeah, very, very surprising it was. And the patient was with us for almost a month, and we couldn't think of it. So there was a learning lesson that, solid organ mets can cause TTP. And in anybody who's refractory, you would then consider doing a bone marrow and a PET scan.
So this postpartum state of antibody production or an autoimmunity situation, we see this in acquired hemophilia A as well. So this pathophysiology is similar to that, not exactly, but yes, it is the B getting rogue and making plasma cells to produce the antibody against something. So anyway, any thoughts on that? Why postpartum immune related? I mean, generally we see that in postpartum, yes. In
Yeah, I mean, occasionally there are patients who, we generally think that, everything happens during pregnancy and, as soon as pregnancy is over, the patient is going to be okay. But every now and then we come across patients who actually present in the puerperial period, and they behave equally badly. So, and then you have to treat them with, with all the regular modalities. Some patients who have developed it in pregnancy may normalize in the postpartum period, but once they develop in the postpartum period, they may require the regular treatment. It doesn't subside on its own. So
so
mechanism, I really don't
breastfeeding
know.
was stopped in this baby.
Breastfeeding was stopped in this baby. Yes, very much.
Okay.
I think this pregnancy correlation could be partly because that 1 Willebrand factor levels increases by 2 to 3 fold during pregnancy, and there is a chance that ADAMTS13 activity is slightly reduced. It's a physiological change during pregnancy, along with the immunological trigger and endothelial injury during delivery. That may be one thing which may be precipitating an immune event post delivery. When I was going through the literature, in some patients, the trigger was an infection or an surgery or a trauma or something. And around 40% patients don't have any trigger, they just have the event.
There are a couple of questions in the chat box. Vijay, do you want to take them up?
No, I think please proceed with the
Second
next case,
Okay.
and then we'll come back and do the chat
Yeah.
box together.
Okay. Rameshwar, please go ahead.
Okay, sir.
Somebody help him out
Okay,
with the screen sharing thing. Okay.
is it coming?
Yeah, it's visible. Go ahead.
Yes.
So, good evening all.
Full on screen sharing. Yeah, na, full
Light show.
full screen mode.
Is it okay? Is it visible? Shall I start?
Yes, Ram, go ahead.
So, good evening all. As I'm going ahead with the second case, elderly male with the massive hemorrhage. So, a 67-year-old male recently diagnosed coronary artery disease came with the massive ecchymotic lesion, left abdominal region, which extending to flank to the left anterior aspect of the thigh from last 1 month, 1 week. Initially started with the reddish appearance, later become the dark red to black, and associated with the pain and not able to flex the left lower limb, not associated with fever, myalgia, any other sites of active bleed. No history of the melena, bowel and bladder habit was normal and regular, and similar recurrent episode in the past 6 months. In view of coronary artery disease, which diagnosed in June 24, he was on ecosprin 75 mg OD for 5 months, then switched to the clopidogrel for a few months, and he was on Ayurvedic medication for a few days. And last 4 weeks, he's not taking any antiplatelet medication. And outside ultrasound suggestive of lesion from left kidney to left psoas muscle, anterolateral aspect of left thigh, which measuring about 10 into 9 into 15 centimeter. Before coming to our hospital, he received 2 PRBC in view of the drastic lowering of hemoglobin. We can see the ecchymotic lesion here, the left flank region, as well as the anterolateral aspect of left thigh. On examination, he was conscious, oriented, hemodynamically stable, no lymphadenopathy, no pedal edema. Systemic examination was normal. Left lower limb in flexion attitude around the hip as well as the knee joint. Extensive ecchymotic lesion extended from the left flank region to interolateral aspect of the thigh. Warmth and tender on touch. So on lab on admission, CBC was like that, hemoglobin 8.3, WBC is 12,100, and platelet is 2,31,000. Whereas the LFT, KFT within normal limit. So we did the PT coagulation profile also, PTA, PTT, INR, and fibrinogen, which was also normal. So we thought of like it's an elderly male with no bleeding history from before 6 months and extensive hemorrhage, not on any drug like the isoniazid or phenytoin. And PET CT, actually we ordered PET CT late. First we started the cryoprecipitate, but the PET CT was within normal limit. Hemogram and coagulation profile picture was also normal. So we thought of the need to rule out the acquired factor 13 deficiency. And in view of that, we send urea clot solubility test, where we can see this in control, this the coagulum is there, but in case of the test tube, there is no the dissolved clot is dissolved. So this is showing the positive urea solubility test. On that basis, we started cryoprecipitate. He received 32 cryo bag in 4 days, and at the same time we sent factor 13 antigen level, and we started on the steroid followed by rituximab, and then planned for the weekly rituximab for 4 weeks, and the patient discharged on day 8. 3 months as of now is in follow-up 3 monthly. With monthly we are doing a urea solubility test, and as of now urea solubility test is after 24 hour. Initially after 15 hour the dissolution of the clot, followed by the 24 hours. Latest CBC is 13.7 hemoglobin, 4,330 is the TLC, and 2,38,000 is the platelet. At present he is doing well with the rituximab maintenance 3 monthly. So here we can add the, meanwhile the factor 13 antigen level, actually 28% before starting and after that we started with, again we sent antigen level, which was 37.9%. So the factor 13 chemistry is the factor 13 is formed in the liver and hematopoietic cells. Half-life is 6 to 10 days, and they basically it exists in 2 forms. One is the plasma form, which is tetrameric form, A2 B2 subunit, whereas the intracellular is dimeric form, exists in the factor 13 A2 subunit. The basic role of the factor 13 is the cross-link fibrinogen to stabilize and strengthen the clot and help in the wound healing, angiogenesis, cytoskeleton remodeling, and even the antibacterial action has been reported. So its deficiency, either congenital deficiency, can be because of this mutation in the subunit, like the alpha subunit or beta subunit. So factor 13B mutation is not so much common. It is less than the 5% of the cases, and level of the, where the circulating B subunit level is low and less severe as the intracellular subunit is intact. Only tetrameric form is involved here. But in contrast to factor 13A mutation, subunit A absent from all compartments. That means the plasma as well as the intracellular, and it is more severe. And in this case, poor wound healing has been reported. So for the management, recombinant factor 13A2 used for the A subunit deficiency. For prophylaxis only, it is not recommended for the acute bleeding episode, and we can go ahead with the 35 international unit per kg once a month to maintain the factor 13 more than 10%. And plasma derived factor 13 concentrate used for either A or B subunit deficiency, both for prophylaxis and acute bleeding episode. And the dose is here 40 international unit per kg once in a month. So prophylaxis is recommended if the patient have recurrent serious bleeding like intracranial hemorrhage or level if it is less than 5%. FFP or cryoprecipitate is used if the recombinant or plasma-derived factor 13 is not available. In case of the pregnancy and pregnancy along with the factor 13 deficiency, infusion begin as soon as possible, like the 5 to 6 week of the gestation to prevent the spontaneous abortion. And perinatal level should be kept more than 2 to 3%. Preferably, if it will more than 10%, then it is good. And 250 unit weekly in early gestation up to 22 week of gestation. Then we can increase it to the 500 unit per week. At delivery, larger dose, that is the 1000 unit, help to keep the level more than 30% to avoid the PPH. And for the surgical prophylaxis, more frequent infusion needed to maintain the more than 20% level of the factor 13. So this is all about the case.
Yeah, so this is a very rare case that today is the first one I have seen. There are very rare case reports. Generally, when it happens in an elderly person, you would always want to rule out a malignancy, a lymphoma, or something. Then that's why we did a PET scan, which turned out to be normal. And so we treated him with cryoprecipitates, and just like we would treat in a with the cryoprecipitate itself, there was significant improvement. It was a reasonably early improvement. So we gave him steroids and then rituximab, and actually after we gave him 4 doses of rituximab and we waited for a while, the factor levels again started to so we were monitoring this patient not by doing a factor level, because as you can see, this patient actually, funnily, we had sent the factor levels to 2 places. One is NIH in Mumbai, National Institute of Immunohematology, and also to Hinduja. Both do antigenic levels. But in both, you can see the levels were pretty good. They were 28%. This was all before the cryo infusion was first given. The first sample that was collected was sent, and the levels were not too bad at all. So with that level, we didn't expect that one would develop any kind of bleeding. Because generally, these kind of bleeds are seen in patients who have a much lower level. So we were wondering whether this is actually not just a depletion of the factor 13, but whether it's actually the antibodies and somehow causing a dysfunctional factor 13, whether it's again some epitope which is causing factor 13 dysfunction. So the urea solubility would probably be more of a functional assay than the other one is an antigenic assay. So probably the dysfunction was very severe, and that is why we decided not to monitor this patient by levels of factor 13, but by the urea solubility test. So, the way we monitored it is we were monitoring how many hours the urea clot is dissolving. So normally it would stay stable for more than 24 hours. Anything less than 4 hours, if it dissolves completely in 4 hours, it's roughly correlated with a less than 1% factor 13 level. So, we tabulated the number of hours in which the clot was dissolving. And that is the way we were crudely monitoring the response. So we saw it declining after a while, and therefore we again put the patient on rituximab maintenance. So now again it has come back to close to some 20 hours or so. So I just wanted to know if any of you have seen a case like this, and I'm sure in CMC you all must have had more cases.
So we had, I think, one patient with same thing, acquired factor 13, finally found to have underlying myeloma.
Oh,
So, and if I'm not mistaken, Joseph, do you remember, was a case presented during this last 1 year of acquired 13? I thought somebody presented. So it is there, but it is, like you said, it's definitely much more rarer than your acquired 8 and 10
yeah,
deficiencies, which we more commonly see. I
yeah.
totally agree.
So one query is, Samir. So we are saying the pathophysiology is some sort of an auto-antibody against factor 13, right? It cannot be
Yeah.
a functional, defect. Is there a
Yeah.
way of looking at antibody to factor 13? Anybody has developed that? Because that would have been the reason of explanation for your levels are good, but functionally it is not working because the functional sites are being impaired.
Yeah, that's what I mean. I don't think there's any way of knowing that, because we checked with
Okay.
NIH, they said it's not possible.
Second is, did you get to do a factor 8 assay on him to see if it is, see if the APTT being normal, it is a time dependent antibody. So the first question in my mind would have been before thinking 13 is, are we missing an acquired hemophilia A, and therefore did we
The
incubate enough
APTT was
to know
dead
that?
normal. APTT is dead
No,
normal.
no, it will be normal unless you incubate it for 2 hours. It could be normal.
Uh,
So immediate correction will be there. APTT immediately will be normal,
the
but only
acquired
it's a
antibodies, are they also time
time
dependent?
dependent. It has a
Acquired
different.
antibodies also time dependent?
Classically, yes, that is when we, I mean, it could have been APTT prolonged, but not correcting. But generally, when we say acquire, I mean, in my understanding, that's a thing. Did you any thoughts on that?
But yeah, Joseph, my thing is, see, you can get that in somebody who's asymptomatic, but if somebody has clinical
Symptoms of
bleeding
bleed,
which is
then APTT will
related
be
to
prolonged.
this, I would have expected a change in the APTT levels.
To some extent.
Without that, it was a bit unusual that the APTT will be absolutely bang normal and they will have clinical bleeding.
Okay.
So, Joseph, I think just go ahead with I think there are a lot of questions in the chat and
Yeah,
the
yeah, yeah.
Q&A.
So first question is Samir and the team, Anu and everybody else here is Abhijit. No, so you're the three consultants here, right? Anybody else?
Yeah, Abhijit is there.
Yes, sir.
Abhijit, Biju, I mean, Abhijit, Samir, and Anu. Very good. I mean, appreciate both the cases. Very nice. So first question is Adams 13 level LDH on follow-up. Now, that I think you had already answered. How is rituximab dosed in a patient is on plasma exchange?
Yeah, that's always the question that is asked, whether you should do it immediately. So what we generally do is that, we've asked this to international experts also, and they don't really bother too much. They just they delay. I mean, what we typically do is just delay the next exchange by, if possible, a day. We try and avoid skip the rituximab on. So we don't do it in the first week most often. We keep doing steroids and plex daily, and just if you can find a window where the platelets have gone up slightly, and you can just defer the plasma exchange by, say, something like 12 hours, ideally about 24 hours, then we just give the rituximab during that time, because once the rituximab is given, it doesn't take any time to bind to its target, right? It will just bind to the target immediately, and then even if the whatever is remaining is washed off from the plasma exchange, it doesn't matter so much. So the thing about giving the rituximab and a few hours later doing the plasma exchange, it doesn't really matter so much.
So essentially, do LDH platelets daily, do plex steroids daily for 5 to 7 days. Once you get a window, make it alternate day, and that time you bring in your rituximab. Is that what you're trying to say?
If possible, but if that's not possible, it doesn't mean we don't defer. We defer the rituximab until you are able to do it on alternate days. We would just give it off and just give the plasma exchange a break by a few hours,
Correct.
8 hours,
Okay.
12 hours, something like that.
Okay. So that is one. Dose wise, you are giving it 1 gram stat dosing, or it is 375
No,
milligram per
so
meter
there's
square.
no known dose. We just do 375 per meter square, the usual dose that we're used to.
Okay. So was molecular test done on this patient? Both
What
these
molecular test?
patients. Say first was Adams 13. So anyway, is there a possibility that it could have
Mm,
been Upso-Schulman?
yeah. Good thought whether she could have this thing, but we documented the antibodies also. Anti-IDMTS
Yeah,
13 antibodies, and in the postpartum period, typically, so we didn't think it was necessary. But yeah, I mean, we could actually have screened for. There's no harm in screening for mutations. But the second
so
patient, surely
what?
there was no indication. He was 70
Correct.
years old.
So where did you do your antigen and the antibody, Adams 13?
So that is done in KEM hospital in Pune. It's done in Pune. There's a nephrologist in Pune who's very, he's a TMA specialist kind of a nephrologist. So he's established all these things long ago. So it
In
just, the
Pune
turnaround
itself.
time is a few days in Pune itself. The KEM hospital,
So,
not Mumbai, but KEM hospital Pune.
okay, so basically the issue is the functionality of the Adams 13 assay. It has to be freshly done.
Yes.
Antibody can
No, no,
still
no,
be
no, no.
done.
Adam certain assay doesn't have to be freshly read. It's an ELISA-based test. So they take the samples, they store them, and then do it batch wise.
Oh, is it?
Or
Antibody
do it
audit.
it's
weekly.
done batch-wise. Yeah, that's
Yeah,
true.
they're doing it weekly. They're doing
Great.
it.
Great.
So just going back to what Joseph said, so I think the molecular actually in a young lady helps because if you have something positive, that helps you plan your subsequent pregnancies
Yeah.
much better.
Agreed. Yeah. So we'll do it in this lady. We should
No,
do
no.
it.
What molecular would you do? Whole exome sequencing or 1 milligrams? I
No, we'll
mean,
just
this.
either clinical exome sequencing or just, we are interested only in the mutations in the von Willebrand factor gene. So,
So clinical exome sequencing would be a
yeah,
reasonable
yeah,
solution.
yeah.
Okay, so factor 13, there is nothing much to add except for giving, I mean, you have already covered nicely the treatment options here,
Yeah.
right?
So Saurabh is saying that if she had congenital TTP, then she would not have responded to plasma exchange and this thing, factors, this thing. But we all know that, so for example, in a TMA, in a HUS, in a atypical HUS, there are many patients who actually have the mutation, and after several years, they actually, when an insult is there, they develop the antibodies against it. Typically in complement factor R1, R2 deficiencies, they are often are congenital, but they don't manifest until there's a major surgical insult or some infection. Then the antibodies are triggered. So you actually have the tendency of developing antibodies with the baseline mutation. So the same thing could apply for TTP also, and I think it is worth in a younger patient screening for mutations.
So to be, I mean, some practical aspects in terms of this things. There are some quick questions on the question and answer session. Aspirin prophylaxis after recovery. How do you monitor RM30s level and frequency immune workup in ANA APLA workup? Aspirin is a reasonable question. Aspirin versus clopidogrel or anything else would you consider?
Aspirin would be definitely considered during the if somebody is developing thrombotic manifestations of a TTP, definitely aspirin would be added on. I think we had added we did add on we did added this on when she had that stroke like episode in between. So we did that. But monitoring it can be only by platelet count. As long as the platelet count is normal, you don't need to monitor any levels.
When you did the plex, did you use cryo or FFP? Cryo supernatant or FFP? Or
We
either
used
also have been
FFP.
tried?
I don't think anybody uses cryosupinated now. Nobody keeps it
Is it?
also. So
Why?
that was only in
After
old
the
CMC days.
cryoprecipitate?
Yeah.
Okay. And one more question. So generally people ask, how many FFPs did you give for
So we
each
do
plex?
so we would do one volume exchange at a time, one plasma volume exchange. So typically we know how to calculate it. 70 ml per kg is the total blood volume, and depending
So
upon what the
40,
hematocrit is, we would decide how much of that is plasma and do one volume exchange.
which
So
means about 10 to 15.
in our hospital, the transfusion medicine department takes up the plex, and it's all done in the blood bank. Or it's all done on a cell separator. The cell separator shifted to the ICU or wherever
Closed.
the patient is, and then that's how it's done.
Very good.
So
So
I
about 10,
think if
50,
you look at the recommendations are you start with one. If you're getting an inadequate response, you can go up to 1.5 times the volume.
Yeah, yeah.
yes.
True. There have been
Dr.
occasions past where we've done double volume exchange also.
Yeah. Dr. Karthik is asking some good questions. What will be your recommendation for the next pregnancy for this primary gravida?
So, very coincidentally, another patient who had postpartum TTP development during pregnancy, and when this patient was admitted, that patient was also admitted for her second pregnancy, in which she developed a vehement TTP. We immediately aborted the pregnancy, and this lady was right in the room opposite the other patient. So she has
So it's
declared for herself that I'm not going to get pregnant again.
easy to counsel. But then you are saying that this happened in the first trimester?
This happened in the no. In this particular
Aborted.
patient, it
You
happened in
said
the
you aborted.
postpartum period. This patient
No,
happened
but
in postpartum period, but the other patient I'm talking about, it happened in the first trimester only. It
no,
happened in
that
the
is a
first
little
trimester.
no. So in fact, Samir,
Mm.
see, during pregnancy, Tregs go up. It's an immunosuppressed state. And it is generally postpartum is a rebound effect of removal of the estrogen progesterone causing a high level of autoimmunity rebound effect. So it is little unusual why she had this in the first case. That entire theory of postpartum immune rebound then is a myth then.
So, and she was a puerperal, so we may consider a second pregnancy. So it's up to her. But she's got one living child, so she's happy with it.
Yeah, but hypothetically, if she came back to you saying, I would like to get pregnant again, I mean, just in general, so that it's a teaching, what would
Yeah.
you look at how to get them through the pregnancy?
Yeah, I mean, we would monitor probably a weekly CBC to begin with, and just monitor very closely to see whether she's developing TTP. If she, I don't think there would be any prophylaxis, but if she does develop TTP, then it'll probably have to be plasma exchanges done during pregnancy. You can do plasma infusion, but plasma exchanges in pregnancy regularly would have to be done. And steroids could be used. You can't use rituximab, but steroids would be safe. So steroids and plasma exchange would be the way to go.
No, Samir, I mean, wouldn't be a better choice to say that I will not recommend pregnancy?
Of course,
Because
that is my
if
first
it
recommendation. But we just giving the
60%
theoretical possibility
mortality,
that she does
13
become
to
pregnant and does have TTP, then what are you
if
going to do? Then
no,
you
no, no.
can
If she
do,
does pregnant first trimester itself, we should suggest abortion, right?
of course.
And if they are adamant to take through pregnancy, the problem is going to happen in puerperium, not during pregnancy, usually.
So yeah, Joseph, we had one lady who was diagnosed when she was a teen as congenital ADAMTS13 with less than 1%. Okay, so it's the congenital variety. But and when
Correct.
she got married, she said, I have to go through. So we actually supported her with monthly FFP through the pregnancy and got her through. Luckily, she was a congenital, so
Yeah,
That
she
is a
you just
key.
developed,
infuse it.
she
Correct.
did
Upsashul.
not have much antibodies, so you could get them through that.
Yeah.
That is possible. That is Upsa Schulman we are talking, right? And now obviously we can do a mutation and probably figure out whether it is confirmatory, right? Um, Thrombocytopenia post chemo refractory can be treated with DARA if meds rolled out. That may be a different question altogether. Okay. So I think we have covered all the questions in the question answer and in the chat bot. Few more have come in. Um, is it's treated with Adams 13 replacement commercial? So is there an Adams 13 replacement other than FFP?
Anu, you're aware?
No, I'm not aware.
Logical thinking, but I guess maybe somebody
Saurabh
can.
can tell us.
Yeah, Saurabh is not into this thing.
Recombinant Adams 13 infusions. Is there a possibility of it being produced?
It's available. Yeah. He's put it there saying it's
So
available
somebody
and
has
not
said
used.
it is available. Saurabh is
Saurabh
saying.
is putting that.
Saurabh Bhave. Oh, very good. Saurabh Bhave, can you enlighten us on that if you are aware of it?
You have to promote him to a panelist, others he can't speak.
Support,
Okay.
can you put
Sure,
Mr. Saurabh
I'll
into the
just switch
So
him
conference?
up.
now that we have 5 minutes left, we can probably get some
Mhm.
understanding on that. I'm in the delegate mode, so make him into a panelist mode.
We will try and switch you, Saurabh.
You seem to know a lot about TTP.
Sir, he
Hmm.
shifted into the panelist. He can talk now.
Okay. All ears, Saurabh. Go ahead.
Used it though, but I had a patient, so I had read about
Hmm.
it, but I am not using it at all. I have never used it. I'll find out the literature and circulate to everybody, sir. It's the treatment which is recommended for congenital TTPs, especially in pregnancy, where FFPs are not a good choice. Rituximab may not be used at all. Plasma exchange doesn't help much. So for a pregnant lady, either it's caplacizumab or it's Adam TS13 commercial oil product replacement. I don't know about safety of caplacizumab in TTP, but Adam TS is used, sir. So I'll send you the literature. I have never used it. Sir, I have one more question. The half-life of factor 13 is 15 days. Then why the replacement is once a month? The second case, na, factor 13 deficiency or dysfunction. The replacement was once a month. At the factor 13 level, half-life is only 15 days. So does that suffice? Double the half-life you replace? Or it's okay? That much low level can just let the patient sail through the bleeding episodes.
I guess it depends on
So,
how much volume you given
no.
initially.
So let me answer that. See, generally, when we give an FFP, say 15, 20 ml per kg, we expect it to go by 20% or more. So the idea was that one, generally factor 13, we say it is after 1 month because the 2 or 3 half-lives we can wait for it to be less than 1%. That
Because
was a
he was
rationale, if
bleeding.
I
So I
understand.
thought, why not a bit early rather than allow him to
If
bleed?
it's symptomatic, we can give early, but
Yes.
generally in a prophylaxis, we give once a month. Isn't it, Biju?
And I think with prophylaxis, you sort of achieve more than 5% levels,
Correct.
which is enough to prevent clinical bleeding.
Correct.
Okay, sir. Okay, sir.
Any further questions?
We are dot on time, 3 minutes left. Thank you, Samir and Anu and your team, Abhijit. Wonderful presentation, and the presenters, students who have done a great job in putting it together. Thank you so much. Back to Diksha.
Thank you.
Yeah, back to Inter.
Thank you. So, as we come to the close of today's episode of Blood the Life Savior, we extend our sincere appreciation to the entire team of Deenanath Mangeshkar Hospital, Pune, for their active participation and academic contribution. We thank Dr. Rameshwar Tiwari and Dr. Siddharth Damle for their well prepared and thoughtfully presented cases, which form the foundation of today's discussion. Our gratitude also goes to Dr. Abhijit and Dr. Anushri Prabhakaran for their insightful clinical perspectives. A special note of thanks to Dr. Samir Malankari for his leadership and bringing together such a committed team. His concluding remarks help tie together the key reflections from today's session. We are deeply grateful to our course directors, Dr. Biju George from CMC Vellore and Dr. N. Joseph Joan from CMC Ludhiana, for their continued guidance and mentorship in shaping Blood the Life Savior into a pan India academic platform for shared learning and clinical exchange. And finally, a heartfelt thanks to all our viewers for joining us today. Your continued engagement, curiosity, and support are what keep this series meaningful and evolving. We look forward to welcoming you to the next episode of Blood the Life Savior. Until then, stay curious, stay inspired, and continue saving life. Thank you and good evening.
Thank you.
Thank you, sir.
Night. Good night. Thank you for joining us.
Thank you, sir. Good night. Support, you can end.
Yes, ma'am. Just allow me 10 seconds.